Chairman Buchanan, Ranking Member Doggett, and members of the committee, thank you for inviting me to testify today. I'm Dr. Colin Edgerton. I'm a community rheumatologist in Charleston, South Carolina. I've been practicing rheumatology for 20 years in the community currently, and prior to that, 12 years as a U.S. Army physician as a rheumatologist, to include deploying to Iraq to support our nation's heroes there. Rheumatology uses biologic medications very heavily, and they have been life-changing for our patients. Prior to the advent of biologics, we had few effective therapies for diseases that led to inevitable disability and early death for our patients. It has been incredible to see the impact of biologic agents on our patients, but we are facing some headwinds regarding the expense of these medications and patient access. The CDC estimates that 21% of adults over the age of 18 have doctor-diagnosed arthritis, so we're talking about a quarter of our population that are potentially going to be treated with biologic agents in the future. Biosimilars have opened up the possibility of greater patient access by significantly reducing the costs associated with treatment for our patients, and we've been very excited to see biosimilars. Have been waiting for them for decades in rheumatology, and now we're living in the biosimilar age. Unfortunately, we are seeing some market distortions that are making access for our patients very difficult, and I'm excited to talk about that with you today. One of the key distortions has been a problem with pharmacy benefit managers offering rebates or extracting rebates, rather, from the manufacturers of the drugs in order to place these drugs on their formularies. Because of the rebates, this reduces the average sales price, or ASP, for these biologic agents. This has led to what we call an underwater situation with the biologic agents, where the reimbursement for the biologic or biosimilar is actually less than the cost of the drug, and therefore patients cannot access the biosimilars. So these are the cheaper drugs. These are oftentimes the drugs that are preferred on the formulary, and the patient cannot access the drug because, again, the cost of the drug is actually higher than the reimbursement. And this is all due to rebates that are being extracted by pharmacy benefit managers. These distortions are a big problem for us in medicine. We'll highlight that pharmacy benefit managers are very opaque organizations that are not accountable to providers like me. I can't meet with them. I can meet with insurance companies. I can meet with the manufacturers, but we cannot meet or talk with the PBMs as providers. I'll also note that the PBMs don't create medications, they don't manufacture them, and they don't care for patients either. They are true middlemen that are extracting billions of dollars from our healthcare system and showing very little as far as results. So what can we do about improving access for our patients with biosimilars? We have several recommendations. One of these is increasing the transparency in drug pricing, especially with respect to biologics and the biosimilars. We feel that this transparency will help both the providers and patients understand the costs involved and foster a more equitable marketplace. Specifically, we need to amend the Social Security Act to temporarily provide an 8% add-on to the provider's acquisition cost of all biosimilar products. Secondly, we recommend amending Section 1847A, Subpart C4, to extend the Secretary's authority to use wholesale acquisition cost, also known as WAC, W-A-C, plus 3% until the ASP, or average sales price, reaches sustainable levels as determined by the Secretary. And thirdly, we recommend amending Section 1847A, Subpart C3, to permanently remove manufacturer rebates from the ASP methodology for biosimilars so that we don't have the underwater biosimilar problem that we currently face. Thank you, and I look forward to answering your questions.